Good day, everyone, and welcome to the webinar of Group 4, where we talk about reduction, fixation, traction, cast, crotch walking, canes and walkers, amputations, and total knee replacements. I am your MC for today, and we'll be joining with our guest speakers, Miss Hannah Clarice Letada, Mr. John Lico, Miss Queen Abriel Lucero, Mr. Jambi Madangit, and Miss Bridget Don Manungas. And let's start with Miss Hannah Caris Letada and with her topic, the reduction.
Hello, Janriel. Thank you so much for your wonderful introduction. So before I begin, if I may ask, how's everybody? Are you all nursing students here? Oh, that's great. So back in the days, I was also a nursing student like you, and who would have thought that I am here now lecturing your webinar, or is about to lecture your webinar. Maybe one day you will too. But anyway, without much ado, let me just begin my lecture. So what is reduction? What is reduction? Who among you here have any idea what reduction is? Anybody? Okay, that's fine. First, I will tell you. Reduction is a surgical procedure to repair a fracture or dislocation to correct the alignment. So for example, you slipped and lost your balance. Then you fracture your bone. So reduction could be one of the procedures to fix the fracture. Okay, so this sense of the term reduction does not actually imply any sort of removal or quantitative decrease, but rather it implies a restoration. So back to its initial position. The stair, lead or brain. So in the stair or reduction, it's bringing back to normal. So when a bone fractures, the fragments lose their alignment in the form of displacement or angulation. For the fractured bone to heal without any deformity, the bony fragments must be realigned to their normal anatomical position. Orthopedic surgery attempts to recreate the normal anatomy of the fractured bone by reduction of the displacement. So don't get me wrong, a fractured bone could actually heal by itself. But once you're not gonna do the process of reduction, or once you're not gonna realign it or fix it, it will forever be disaligned. You know, the alignment isn't how it's it's real anatomical position anymore. It's normal anatomical position anymore. That is why we have these things to correct. Okay, we have two types of reduction. You have the open reduction and the closed reduction. So open reduction is where the fracture fragments are exposed surgically by dissecting the tissues. So this is an invasive procedure. Whereas the closed reduction is the manipulation of the bone fragments without surgical exposure of the fragments. So that means there's no opening needed or any invasive procedure needed for the closed reduction. But because the process of reduction can briefly be intensely painful, it is commonly done under a short-acting anesthetic, sedative, or nerve block. Once the fragments are reduced, the reduction is maintained by application of casts, traction, or held by plates, screws, or other implants, which may in turn be external or internal. It is very important to verify the accuracy of the reduction by clinical tests and x-rays, especially in the case of joint dislocation. So I have here types of fractures. So here we have the normal. Okay, you can see the normal bone, but once it is a transverse fracture. So a transverse fracture is when the fracture line is perpendicular to the shaft of the bone. So as you can see here, it's perpendicular. It's like chopped. Then we have here the open or compound. So an open fracture is also called a compound fracture. So it is a fracture in which there is an open wound or break in the skin near the site of the broken bone. So as you can see here in the illustration, diba, it's on the outside part, meaning it's there's already an open fracture. So the site or like the bone can already be seen from the wound in the body. And then we have the oblique. So oblique fractures are a type of broken bone. They happen when one of your bone is broken at an angle, like this. Okay, so you can see in the illustration. So you might see oblique fractures referred to as a complete fractures. This means the line of the break goes all the way through your bone. So diba? And then the oblique displaced, it's like the oblique, but the displaced fracture means the pieces of your bone moved so much that a gap formed around the fracture. So see, you see the difference of the oblique and the oblique displaced? There is a gap. So that's the difference. And then we also have the segmental. Segmental fracture, a type of broken bone. They happen when one of your bone is broken in at least two places, leaving a segment of your bone totally separated by the breaks. So segmental fractures are caused by severe traumas like car accidents. And this is avulsed, as you can see. An avulsion fracture is an injury to the bone in a location, excuse me, in a location where a tendon or ligament attaches to the bone. When an avulsion fracture occurs, the tendon or ligament pulls off a piece of the bone. We also have the spiral. Spiral fractures are a type of broken bone. They happen when one of your bone is broken with a twisting motion. They create a fracture line that wraps around your bone and looks like a corkscrew. You might see spiral fracture referred to as a complete fracture as well. And then we also have a green stick. A green stick fracture occurs when a bone bends and cracks instead of breaking completely into separate pieces. The fracture looks similar to what happens when you try to break a small green branch on a tree. So we also have the comminuted. Sorry for that. So this type of fracture, so a comminuted fracture is a type of broken bone. So the term comminuted fracture refers to a bone that is broken in at least two places. So as you can see in the illustration, comminuted fractures are caused by severe traumas, also like a car accident. So you will need surgery to repair your bone, especially if this is the type of fracture that the patient is experiencing. So next is that we have the laboratory exam that is needed before we proceed with a reduction. So to determine the presence of fracture, the following diagnostic tools are used. First is, of course, X-ray examination, because this determines location and extent of traumas that may reveal the pre-existing and yet undiagnosed fracture. And then we also have bone scans, tomograms, CT scan, and MRI scans. So it visualizes the fractures, bleedings, and soft tissue damage, differentiates between stress or trauma fractures and bone neoplasms. And we also have arteriograms. So it may be done when an occult vascular damage is suspected. Then the complete blood count, because the hematocrit may be increased or decreased. Increased white blood cell though is a normal, white blood cell count is a normal stress response after trauma. We also have to check for the urine creatinine clearance, because muscle trauma increases the load for creatinine and for renal clearance. And then lastly, you also have the coagulation profile. Alterations may occur because of blood loss, multiple transfusion, or liver injury. Then we proceed to the medical intervention. So immediately after injury, if a fracture is suspected, it is important to immobilize the body part before the patient is moved. Because of course, an additional movement may actually A movement may cause an additional damage to the already fractured bone or the suspected fractured bone. So we have to prevent that one. Then we have adequate splinting. So it is essential to prevent, like what I mentioned, the movement of fracture fragments. In an open fracture, the wound should be covered with a sterile dressing to prevent contamination of the deeper tissues. Because fracture reduction refers to the restoration of the fracture fragments' anatomic alignment, like what we mentioned earlier, and positioning, and can be open or closed depending on the type of fracture. So lastly, we also have the nursing intervention. I'll just provide three. So for the closed fracture, the patient with closed fracture is assessed for absence of opening in the skin at the fracture site. So that is when we determine that it is a closed fracture, when there is no opening or there is no wound involved. For the open fracture, the patient with open fracture is assessed for risk of osteomyelitis, tetanus, and gas gangrene. We all know what is tetanus already. So I'll just give you information regarding osteomyelitis, just an add information. It is an inflammation or swelling that occurs in the bone. Sometimes it can result from an infection somewhere else in the body that has spread to the bone, but it can also start in the bone itself, often as a result of an injury. And also, for gas gangrene, it is mostly commonly caused by infection with bacterium called Clostridium perfringens. Bacteria gathered in an injury or a surgical wound that has no blood supply. So that could actually happen when you have a fracture. So the fractured site is assessed for signs and symptoms of infection. So that would be all for reduction. Thank you so much for your time in listening. And I hope you learned something you enjoy. Okay, the rest of the webinar. Because there are other more interesting topics that will be discussed by other lecturers. Thank you so much.
Thank you, Miss Litada, for that wonderful discussion about reduction. And next is our guest speaker, which we will be they will be talking about fixation, and that is Miss Queen April Lucero. So
Now let's tackle about fixation. So what is fixation? Fixation in orthopedics is the process by which an injury is rendered immobile. This may be accomplished by external fixation using intramedullary rod, Crutches wire, or dynamic compression plate, or by external fixation using a spanning external fixator, Taylor spatial frame, or Elizarov apparatus. Fractures can be treated conservatively or with external and internal fixation. What is internal fixation? It is a surgical procedure that stabilizes and joins the ends of fractured or broken bones by mechanical devices such as metal, plates, pins, rods, wires, or screws. So next, we have external fixation. It is a device placed outside the skin that stabilizes bone fragments with pins or wires connected to bars. Relative stability healing with callus. Now I'll be showing you a short video.
Wrist fractures are very common injuries. They are most frequently caused by a fall on an outstretched hand. The type and location of the fracture depends on the position of the wrist during impact and the direction of the force. Symptoms can range from minor swelling and aching pain in the wrist to significant swelling, deformity, and black and blue discoloration of the wrist and hand. Most wrist fractures are treated non-surgically, usually with a cast. However, surgery may be necessary for fractures in many pieces, unstable fractures, or fractures that disrupt the wrist joint surface. The type of surgery that you need depends on the location and pattern of the wrist fracture and bone quality. Open reduction and internal fixation is a procedure that uses surgical hardware to stabilize a fracture beneath the skin. The bones are reduced, realigned in the proper position, and fixed, held in place with surgical hardware. Depending on the type of surgical hardware, it may remain in place after the bones have healed. Let's take a closer look at the surgical procedure. To begin, an incision is made along the forearm over the fracture. The tendons and muscles are carefully moved to allow access to the bone. The fractured bone is then realigned. Next, the bones are secured together with the surgical hardware. The tendons and muscles are placed back in position and the incision is then closed. Your wrist will be wrapped in a soft dressing and a splint to provide support. As you recover, therapists will show you exercises to help you regain movement, strength, and function. Recovery from open reduction and internal fixation surgery is individualized and depends on the severity of the fracture. A full recovery usually takes several months. Your doctor will let you know what to expect.
Thank you, April. Now we'll proceed in discussing the nursing intervention for fixation. Now, the preoperative care for fixation first, ver- um, verify the doctor's order, perform hand hygiene as always, and confirm the patient's identity using at least two patient identifiers according to your facility's policy. Always reinforce the doctor's explanation of the procedure and answer the patient's questions if there are any clarifications or questions that will be asked to you from the patients. Always ensure to answer it and give clarifications to her or his questions. Always ensure that the patient has signed a consent form according to your facility's policy. And then, perform a comprehensive pain assessment using techniques appropriate for the patient's age, condition, and ability to understand. Assess also the patient for pain and administer pain medication as prescribed, no, using safe medication administration practices. Now, perform a follow-up pain assessment and notify the doctor if pain isn't adequately controlled. Tell the patient what to expect during post-operative assessment and monitoring. Teach the patient how to cough, deep breath, and use an incentive spirometer to reduce the risk of post-procedure pneumonia. Prepare the patient also for proposed exercise and progressive ambulation regimens if necessary. If necessary lang. Then, conduct a pre-procedure verification to make sure that all relevant documentation and related information or equipment is available and correctly identified to the patient's identifier. And always verify that the laboratory and imaging studies have been completed as ordered by the physician and that the results are in the patient's medical record. Always um put that in mind as a nurse, no? Notify the doctor of any unexpected results from the imaging studies, no? CT scans, x-rays, and then ensure that the patient has or had nothing by mouth for 6 to 8 hours before the procedure, except in emergency situations. Then, verify that the patient has patent IV access to administer prophylactic antibiotics or for IV fluids or blood products as prescribed by the physician. And always and never forget to perform hand hygiene and document the procedures done and any assessment that you have done to your patient. Now, in during the post-operative care, always perform hand hygiene to prevent nosocomial infection or um, development of infection to the patient's wound or surgery wound. And yeah, and I guess that's it for the nursing interventions and considerations for the fixation. Thank you.
Thank you, Miss Lucero, for that incredible discussion and insights about fixation. Next, we will be joining with our speaker, Mr. John Relico, for his topic, traction.
Good day, everyone. This is Mr. Lico, and in this moment, we will be discussing about types of traction. But first, let us define what is traction. Traction refers to the practice of slowly and gently pulling on a fractured or dislocated body part. It's often done using ropes, pulleys, and weights. These tools help apply force to the tissue surrounding the damaged area. The purpose of traction is to guide the body part back into place and hold it steady. Traction may be used to stabilize and realign bone fractures such as broken arm or leg. It also helps reduce the pain of a fracture before surgery. And also, it treats bone deformities caused by certain conditions such as scoliosis, lordosis, kyphosis as well. Traction also correct stiff and constricted muscles, joints, tendons, or skin, and also stretch the neck and prevent painful muscle spasm. Now let's proceed to discussion of the types of traction. The skeletal traction is a treatment method for broken bones. It's a system where a combination of pulleys are used to promote the healing of fractured bones. These are usually in the lower body, and in skeletal traction, a pin rather is placed inside your bone. That pin provides a base for a pulley system, and it uses gradual pulling force to realign broken bones and promote proper healing. There are two common types of traction. Namely, this includes the skin traction and skeletal traction. Now, the difference lies in where the pin or base is placed, and skeletal traction uses a pin inserted into your bone. In skin traction, a splint or adhesive is applied to your skin. And these days, it's used as a pre-operative treatment. Using skeletal traction can help realign your bones when your fracture is unstable. Now, as you can see in the slides, these are the examples of skeletal tractions, no? You can see an example sa elbow, and then in the femur area, in the knees, and in the ankle, no? Now, the skeletal traction involves placing a pin, wire, or screw in the fractured bone. After one of these devices has been inserted, weights are attached to it so the bone can be pulled into the correct position. This type of surgery may be done using a general, spinal, or local anesthetic to keep you from feeling pain during the procedure. The amount of time needed to perform skeletal traction will depend on whether it's a preparation for a more definitive procedure or the only surgery that will be done to allow the bone to heal. Now, the skeletal traction is most commonly used to treat fractures of the femur or thigh bone, and it's also the preferred method when greater force needs to be applied to the affected area. The force is directly applied to the bone, which means more weight can be added with less risk of damaging the surrounding soft tissues. Now let's proceed with the skin tractions. As you can see the examples there. Now, skin traction is far less invasive than skeletal traction. As we have as I have discussed beforehand, skeletal traction used a pin, no, attached to the bones. Now, it involves applying splints rather, bandages, or adhesive tapes to the skin directly below the fracture. Once the material has been applied, weights are fastened to it. The affected body part is then pulled into the right position using a pulley system attached to the hospital bed. Now, the skin traction is used when the soft tissues, such as the muscles and tendons, need to be repaired. Less force is applied during skin traction to avoid irritating or damaging the skin and other soft tissues. Skin traction is rarely the only treatment needed. Instead, it's usually used as a temporary way to stabilize a broken bone until the definitive surgery is performed. Now we'll proceed to the role of the nurse in caring for patients in traction. First, the role of the nurse shall not apply or set up skeletal or cervical traction. We are not allowed to do that. And also, the registered nurses shall not remove, add, or lift up on weight when the patient is in traction for the treatment of fractures. Number three, registered nurse may remove or add weights to balance suspension, not only to balance suspensions or slings, which is used with skeletal traction, but we cannot remove, add, or lift the weight, only the to balance. Now, registered nurses shall not release a patient from traction for the purpose of transfer to and from bed, stretcher, or procedure tables. Now, the nurse shall notify the physician so the physician may come and remove traction for transfer and to replace traction. Registered nurses shall provide pin care per physician's order. Now, the care for patients in traction. First, when assisting with AM and PM care, encourage the patient to do as much for himself as is possible within the constraints of his immobilization, and also assist with or perform those tasks that the patient cannot perform. Second, assess the patient and the traction setup to determine the best method for changing the bed linen. There are several acceptable methods for making an occupied bed, and depending upon the type of traction in use, no, you will want to use the method that is easiest. Now, for some patients, a head-to-toe technique may work better than side-to-side. Always be sure that the linen is smooth and dry. Utilize draw sheets when appropriate. Reposition supporting pillows and change the pillowcases as often as needed to prevent the patient from being supported by soiled, damp, wrinkled, or flattened pillows. Now, third, when assisting with the bedpan or urinal, provide adequate time and privacy for the patient because many patients do not adjust easily to the awkwardness of using a bedpan or urinal. The presence of roommates, visitors, or hospital personnel just outside the privacy curtain is enough to make anyone uncomfortable. Now, always place toilet tissue, moist towelettes, and call bell within easy reach of the patient. Check daily to see whether the patient has had a bowel movement. Treating constipation will prevent the more serious problem of fecal impaction, and physicians will routinely prescribe a stool softener for immobilized patients in order to prevent constipation. Always encourage the patient to eat all the prescribed diet, and if permitted by the physician, suggest to family and friends to bring fruit or a healthy favorite food from home. A recovering patient's diet should be high in calcium, first calcium, then protein, iron, and vitamins to increase the healing process no, of the patient. Plenty of fluids and foods high in roughage will help prevent bowel and bladder complications. Then, assist the patient to take several deep breaths each hour. Coughing and deep breathing will help prevent respiratory complications and encourage the patient to actively exercise the unaffected extremities. Now, eliminate any factors that reduce the traction pull or alter its direction. Ropes and pulleys should be rather in straight alignment, and the ropes should be unobstructed. Traction is not accomplished if the knot is in the rope is touching the pulley or the foot of the bed. The weights the weights must be suspended not in contact with the bed or resting on the floor. The patient's body should always be in alignment with the force of traction, and check the patient's position each time you enter the room and help the patient slide up in bed if necessary. Encourage always the patient to use the overhead trapeze instead of elbows to move in bed. Now check the extremities for color, pallor or cyanosis, the numbness, edema, signs of infection, and pain. Look for areas of skin breakdown or pressure sores on all skin surfaces. And then orthopedic patients confined in traction will need some sort of diversional activity to relieve boredom and prevent depression. If your treatment facility has no occupational therapy department, encourage family and friends to visit frequently and bring books or games for the patient for him or for her to not be, feel the boredom during the confinement or admission. Television and radio may also help to pass the time. The nursing personnel should make opportunities to stop and chat with the patient, both to distract the patient from boredom and to assess the patient's mental status as well. It is often easy to see a state of depression beginning, and it will be easier to dispel in its early stage. Now, I guess that's it, and thank you for the wonderful time and for your uh, listening. God bless.
Thank you so much, Mr. Lico. That was indeed incredible and very interesting topic to talk about. Um, Next, we'll be joining again with our guest speaker, wherein she already talk about the topic about reduction. So here it is again, Miss Hannah Carisletada for her topic, the cast.
Hello once again. I am back for another topic. Thank you, Jambi. Anyway, how's the webinar so far? Are you all still here? All ears on me, okay? So let's move on to my next topic, which is cast. I believe we are all familiar with casts, right? I think at least once in our life, we've already seen someone who's wearing a cast. So, what is cast? A cast holds a broken bone in a place as it heals. Casts also help prevent or decrease muscle contractions and are effective at providing immobilization, especially after surgery. Casts immobilizes the joint above and the joint below the area that is to be kept straight and without motion. So, for example, like what I've said earlier for reduction, you slipped and then you fractured your bone. So, you will have a, like, let's say, forearm fracture. And then you will need a long arm cast to immobilize the wrist and the elbow joints. So what are casts made of? The outside or hard part of the cast is made from two different kind of casting materials. So we have two. One is the plaster. It is white in color, and then the next one is the fiberglass. This one is the one that comes in a variety of colors, patterns, and designs. So cotton and other synthetic materials are used to line the inside of the cast to make it soft and to provide padding around bony areas such as the wrist or elbow. So special waterproof cast liners may be used under a fiberglass cast, allowing the person who's injured to get the cast wet. So you may talk to the healthcare provider for special cast care instruction for this type of cast. So we actually have various type of casts. So I will be showing you a table in which we can see what are the uses, also the areas as to where the cast is used. So the type of cast, short arm cast. The location for this type of cast is applied below the elbow to the hand. Its uses is in the forearm or wrist fractures. It also used to hold the forearm or wrist muscles and tendons in place after surgery. And then we have long arm cast. It is applied from the upper arm to the hand. So it's used for upper arm, elbow, or forearm fractures. Also used to hold the arm or elbow muscles and tendons in place after surgery. And we also have arm cylinder cast. So it is applied from the upper arm to the wrist. Its uses is to hold the elbow muscles and tendons in place after a dislocation or surgery. Then we have shoulder Pica cast. It is applied around the trunk of the body to the shoulders, arm, and hand. So this is for shoulder dislocations or after surgery on the shoulder area. The Minerva cast is applied around the neck and trunk of the body. So this is for after surgery on the neck or upper back area. And then we have short leg cast. It is applied to the area below the knee to the foot. It is used for lower leg fractures, severe ankle sprains and strains, or fractures. It is also used to hold the leg or foot muscles and tendons in place after surgery to allow healing. And then we have unilateral hips Pica cast. It is applied from chest to the foot on one leg. It is for thigh fractures, also used to hold the hip or thigh muscles and tendons in place after surgery to allow healing. And then we have 1 1/2 hips Pica cast. It is applied from the chest to the foot on one leg to the knee of the other leg. A bar is placed between both legs to keep the hips and legs immobilized. This is for thigh fracture. It is also used to hold the hip or thigh muscles and tendons in place after surgery to allow healing. And then we have the bilateral long leg hips Pica cast. So this is applied from the chest to the feet. A bar is placed between both legs to keep the hips and legs immobilized. So this is used for pelvis, hip, or thigh fractures. It is also used to hold the hip or thigh muscles and tendons in place after surgery to allow healing. And then we have short leg hips Pica cast. It is applied from the chest to the thighs or knees. It is used to hold the hip muscles and tendons in place after surgery to allow healing. And lastly, we have the abduction boot cast. It is applied from the upper thighs to the feet. A bar is placed between both legs to hold the hip muscles and tendons in place after surgery to allow healing. So how can the patient move around while in a cast? So we have different assistive devices. This is not just for children, but for anyone who actually have a cast. So it includes the crutches, and then we have walkers, then wagons, wheelchairs, and also reclining wheelchairs. And then what laboratory exams do we need when we will be applying or when we will be putting a cast to a patient? So the common orthopedic tests include bone densitometry, skeletal scintigraphy, discography, myelography, and electromyography. Most of these tests rely on proven technologies such as X-ray, MRI, ultrasound, and computed tomography. Other tests such as flexibility tests, stress tests, muscle test, and gait analysis may be used to assess range of motion or identify abnormalities in skeletal alignment or muscle function. Additional tests, including muscle biopsy and bone marrow biopsy, may be needed in certain cases to help narrow down the diagnosis. And then we have our nursing intervention. So for your future nurses, the one that your nursing intervention should include, but this doesn't limit to only this, okay? So you may first is you may prepare the client for cast application. So you have to explain the procedure and what to expect, and also obtain informed consent if surgery is required. You have to clean the skin of the affected part thoroughly. Next is you have to assist the healthcare provider during application of the cast as needed. And then after cast application, provide cast care. You have to support an exposed cast with the palms of your hands to prevent indentations. Ensure that the stockinette is pulled over rough edges of the casts. This is to avoid, the connection of the skin and the rough areas of the cast, because it might actually create or cause wounds. So that will be an additional problem because it might actually also be infected in the long run. Then we need to provide covering and warmth to uncasted areas. Next is we have to expose the fresh plaster cast to circulating air, uncovered until dries 24 to 72 hours. Expose the fresh synthetic cast until it is completely set for about 20 minutes. Then you have to instruct the client. You have to instruct the client to avoid wetting the cast. Instruct him to dry a synthetic cast with a hair dryer on full setting if it gets wet. And then we have to initiate a pain relief measure if indicated. So encourage position changes, elevate the affected body part, provide analgesics as appropriate, promote non-pharmacologic pain relief measures such as guided imagery, relaxation, and distraction. Next, we have to observe for signs and symptoms of Caste syndrome with clients who are immobilized in large casts, such as a body or hip Pica cast. We have to report abdominal pain and distension, nausea and vomiting, elevated blood pressure, tachycardia, and tachypnea, which are physiologic effects of Caste syndrome. Any client who is claustrophobic is at risk for psychological Caste syndrome, which includes acute anxiety and possible irrational behavior. Next is to provide nursing care for compartment syndrome if indicated. Observe for signs and symptoms and discuss and assist with treatments. You have to notify the healthcare provider immediately if signs or symptoms of other neurovascular complications occur. Then notify the healthcare provider if hot spots occur along casts that may indicate infection under casts. Then you have to provide client and family teaching. Encourage isometric exercises to strengthen muscles covered by cast. Promote muscle strengthening exercise for the upper body if crutches are to be used. Advise the client to promptly report cast breaks and signs and symptoms of complication like circulatory compromise, cast syndromes, and hot spots. Teach the client skin care and muscle strengthening exercises for the affected body part after cast removal. Encourage mobility and active participation in self-care. And then lastly, reinforce healthcare provider instruction on the amount of eight bearing allowed. Then the medical interventions that we have is preparing the injured area. So to prepare the injured extremity for splinting, stockinette is measured and applied to cover the area and extend about 10 centimeters beyond each end of the intended splint side. Later, once the padding and splint material have been applied, the excess stockinette is folded back over the edges of the splint to form a smooth padded edge. Care should be taken to ensure that the stockinette is not too tight and that wrinkling over flexion points and bony prominences is minimized by smoothing or trimming the stockinette. Generally, a stockinette 2 to 3 inches wide is used for the upper extremities and 4 inches wide for the lower extremities. Measuring the stockinette. Black lines indicate the ends of the intended splint. Ulnar gutter splints is used to illustrate the procedure. This splint is commonly used to treat a boxer's fracture, but may also be used to immobilize fractures and serious soft tissue injuries of the 4th and 5th fingers and metacarpals. Alternate splints are chosen for other injuries. In cast application, the principles of casting are similar to those of splinting. Once the extremity has been prepared with stockinette and padding and placed in the desired position, the plaster of fiberglass material is applied. The casting material is wrapped circumferentially with each roll overlapping the previous layer by 50%. The physician should avoid placing excess tension in the plaster or fiberglass because it can create a tight constrictive cast that may damage underlying skin through pressure, neurovascular compromise, or both. And then conversely, a cast that is overly padded or loosely applied can allow for significant rubbing, friction, and skin injury, like abrasions or friction blisters. Just before the final layer of casting material is applied, the physician should fold back the stockinette and padding, and then apply the final layer, molding the cast while the materials are still malleable. So that would be all for cast. Thank you so much for listening, and I hope that you've enjoyed the discussion. Thank you.
Well, thank you again, Miss Letada for that wonderful discussion. Next, we'll be joining again by another speaker, and it is Miss Queen Lucero for her topic, Crotch Walking.
Good day, everyone. Thanks for having me. I'll be discussing the crotch walking, the 2-point, 3-point, 4-point, and swing point gait. Crotch walking is assisting patient to walk using crutches while providing support as a convenient method of getting from one place to another. Gait. Gait is a term to describe human locomotion. It is a pattern of walking or a sequence of foot movements, such as the 2-point crutch gait, 3-point crutch gait, 4-point crutch gait, and the swing point crutch gait. Crutches. These are devices which are used to reduce weight bearing on one or both legs and also give support where balance is impaired and strength is inadequate. So the following are the types of crutches. First, we have the axillary crutch, left strand crutch, and elbow extension Canadian crutch. We have some considerations or prerequisites for crutches. First is good strength of upper limb muscles is required. Range of motion of upper limb should be good. Shoulder adductors, elbow and wrist extensors, and finger flexors. The advantage of underarm crutches or axillary crutches is that it allows the patient to perform a greater variety of gait patterns and ambulate at a faster pace. Whereas one of its disadvantages is that axillary crutches require good standing balance by the patient. For the elbow crutches, the advantage is that it is easily adjustable and it requires no more energy. Meanwhile, its disadvantages is that elbow crutches are less stable and it requires good standing balance and upper body strength. Lastly, we have the forearm support crutch. Its advantages are easily adjustable and more cosmetic than other crutches, whereas its disadvantages provides less lateral support due to absence of axillary pad. Cuffs may be difficult to remove and this can be expensive. Here are the demonstrations for the 2 points, 3 points, 4 points, and swing point gait.
So they move the right crutch and they move the left foot together. Then they will move the left crutch on that non-injured side and the right foot together. So you have 2 points. Move the right crutch, which is, we'll say, the injured side. Then they'll move the left foot. Then they'll move the left crutch. And then they'll move the right foot. And this is where they move both crutches and the injured leg together at the same time, and then they will move the non-injured leg, where the patient will move both crutches forward. Then they will hence swing or move both legs forward and place them at the placement of where the crutches are located. They will move both crutches forward. Then they will move both legs forward, hence swing both legs forward, but they will swing it past the crutch placement.
Nursing and medical intervention. Standard axillary crutches need 2 adjustments: the length of the crutch and the position of the hand grip. Prior to adjusting, prepare the crutches with padding on the axillary bar and a rubber tip on the end of each crutch. Have the patient lie supine, arms at sides, wearing a shoe on the unaffected foot, using a tape measure. Measure from the axilla to the heel of the shoe and add 2 inches. Adjust the crutch shaft to this measurement. Place the crutch along the patient's unaffected side with the axillary pad at the axilla and the crutch tip 6 to 8 inches to the side of the heel. Adjust the crutch to fit his length. Next, have the patient stand at the bedside with the crutches in place and grip the handbars. You should be able to fit 2 fingers between the axilla and the axillary bar when the patient is standing in the tripod position. Adjust the handbar so that the patient's elbow is flexed approximately 30 degrees when the hand grips the handbar. Then check each crutch for proper fit and ask the patient if the crutch feels comfortable. To make it more understandable, I hope this video helps.
So let's get started. For exams in nursing school, you want to make sure that you are familiar with assistive devices, such as crutches, canes, and walkers. And in our next videos, we will be talking about canes and walkers. So with crutches, what you specifically want to know for exams is how they should properly fit, the different types of gaits you can do with crutches, how a patient should go up and down the stairs with crutches, and how they should get up or sit down in a chair. So first, let's talk about proper fit. What are some things that you need to see in your patient that tells you that those crutches fit them properly? Well, before a patient even starts using crutches, the crutches will have to be adjusted based on the patient's height. And they can be adjusted at the bottom and at the top. And usually on most crutches, there's a height range where you will slide the part of the crutch to meet whatever your patient's height is. Also, there's a hand grip on the crutch that can be adjusted as well. So some things you want to remember is that you want to be looking at the gap between the crutch rest pad and the axilla, the armpit. There should be a gap there. It should be about 2 to 3 fingers width, which ends up being about 1 to 1.5 inches. And the reason you want this gap is because while the patient is using the crutch, they need to be putting all their weight on the hand grips rather than on this crutch rest pad via the axilla area. Because in this area you have nerves, and if they're putting all their weight on that, number one, it's really going to be uncomfortable and hurt, but it's also going to damage those nerves in that area. Also, you want to be looking at the hand grips and where they're lining up on the body. The hand grip should be even with the top of the hip line. So whenever the patient actually uses the hand grips, their elbow will be slightly bent at about 30 degrees. Now let's talk about the different types of gaits while using crutches. And you want to make sure that you really truly understand these different types of gaits that I'm going to go over, because exams love to give you a description of a gait that a patient may be doing while using crutches, and you'll have to identify it. So before a patient even starts ambulating with crutches at first, you want to make sure that they are wearing a gait belt for safety. Also, before they start doing one of these type of gaits, they're going to start in the tripod position. And it looks something like this, and it forms like a triangle, hence looks like a tripod. And this is where the crutches are about 6 inches out diagonally from the feet.
Thank you so much, Miss Lucero. And next is another speaker. He is Mr. Jambi Madangit, and he will be talking about the canes and walkers as well as the amputations. So let's talk about canes and walkers. I am your speaker, Jambi Madangit. So let's first know what is cane and walkers. So canes are designed to provide balance and support in standing and walking, and they take some pressure off one or both legs to improve feeling of safety and security when walking. So there are so many to choose from wood and metal right up to the state-of-the-art carbon fiber. So they could come in a traditional or a range of modern colors and patterns. So there are some sticks that fold up to fit in a carrying case or handbag, and some are adjustable to make it easier to get the correct length stick. So a range of handle styles are available including T-shaped, offset, crook, swan neck with and ergonomic or athletic handles. So these are designed to provide support under the palm. So as you can see, these are the T-shaped cane and the offset cane. So also this is the swan cane and the crook cane. So the 4-point sticks, it is also known as a quad sticks, provide a wider base of support than the more common single point stick. So but they could also create a they can also be a tripping hazard because of the width, their increased side width. So canes or walking sticks are used widely to reduce pain and also to improve your balance and stability. Um, but they are um, usually used very they are usually used incorrectly, and this could be resulted to a dangerous or hazardous events. So it's important for us to educate them about this to obtain a great benefit from their canes or walking stick, and for the necessity to check it regularly for defects to ensure safe usage. So there are various types of hand grip, including the handle. The benefit of the handle is that it has a good grip and control. The crook handle is useful for hanging up the stick. The swan neck is the benefit of the swan neck handle. It makes the stick feel more balanced, and the Fisher stick or ergonomic stick handle, it fits your hand closely and good for stiff or painful hands. So the gait disturbance categories, these are the balance. Um, Under the balance is the sensory and cerebellar systems, the motor, including the cerebral initiation of walking and muscular strength, and joint or skeletal problems. So types, there are some different types of ambulatory assisted devices and their types, modifications, fitting, stability, and indication for indication. So the type used is dependent on the type of the gait disturbance. So first is the single point walking sticks or the SPS. So these are the standard canes that can also be called also as a straight cane, and generally it is made of wood and aluminum. They are lightweight and very cheap. So the length of the wooden standard canes must be custom fitted to the specific patient, while the aluminum standard cane have pins for length adjustment, so there is no need for custom fitting. So these canes are very useful for patients that only need a additional point of contact with the floor for them to create balance with little or no weight bearing needed. So this cane also can be used for patients with sensory coordination problems found in visual, auditory, vestibular, peripheral, proprioceptive, or central cerebellar disease. So next is the offset canes. These canes are usually made from aluminum, and the lengths are also adjustable with no need for custom fittings. So These canes allows the patient's weight to be displaced over the shaft of the cane. So this cane provides more stability and can be used for occasional weight bearing. So the patients that will be using this are those with painful gait disorders like that of mild to moderate antalgic gait cutting from hip or knee osteoarthritis. So next is the multiple legged canes or quad cane. This is a four-leg cane usually made of aluminum. So this cane permits more weight bearing, increases base of support, and provides more stability for the patient. It can also stand by itself, freeing the patient to use his or her hands. So one disadvantage for this is, is that the all four legs must be in contact with the floor during gait to provide stability, which hinders fast gait. So it can be prescribed for hemiplegic patients or patients with moderate to severe antalgic gait from osteoarthritis. The Hemi Walker, it is also known as a walk cane, and it's made of aluminum with a vertical component, a handle with two legs, and another component with two additional legs angled away from the patient. So this cane provides more broad-based support than other canes. So the patients that will be using this requiring continuous weight bearing through one upper extremity like stroke patients with hemiparesis with who have moderate to severe lower extremity disability. So let's go with measuring canes. So to measure the height of any walking stick, the base of the stick should be placed approximately 15 centimeters from the outside of the foot, and the handle height should be set at the wrist height. So the elbow should be bent slightly, generally between 15 and 30 degrees when holding the stick and standing upright. So how to use a cane? So for the gait, walking sticks are usually used on the ineffective or strongest side of the body, but this may depend on individual preference and abilities. So the stick should be placed forward at the same time as the effective leg, then the ineffective leg follows. So if using two sticks at the same time, a 4-point gait may be used by bringing one stick forward, then the opposite leg, then the other stick, followed by the opposite leg. So the 4-point sticks with an offset base should be positioned so that the straight side of the base is nearest to the body. All points of the stick should be maintain contact with the ground when the stick is placed down. So in the stairs, to negotiate going up steps and stairs, you lift the unaffected leg onto the first, then stick and the affected leg onto the same step. Travel down, the stick and the affected leg should be lowered first, then the unaffected leg down to the same step. So next is the sit stand, from sitting to standing. So first is to position the cane on the unaffected side of the patient. Then advise the patient to move the edge of the seat, holding the cane handle and bear weight on the unaffected leg, and cane to come up to the standing position. So make sure the height of the cane is appropriate with the level of greater trochanter to ensure elbow flexion is 20 to 30 degrees and the cane is 2 inches in front of the affected leg and 6 inches to the side of the affected leg. So instruct the patient to approach the chair or bed and turn in small circles toward the stronger side till the back is facing the chair or bed. So assist the patient to back up the chair until the chair can be felt against the back of the patient's leg. So instruct the patient to reach for one arm rest at a time, so the patient lowers to the chair in a controlled manner. So safety tips, you need to inspect your cane on a regular basis. So You need to make sure the cane has a rubber stop for shock absorption and grip to prevent slipping. So also, always check the cane for worn tips and handles, and always make sure that the cane is at the proper height to avoid imbalance and bad postures. So that's all for the canes and walkers. So thank you so much. So thank you for that wonderful introduction. So good day everyone. I am your guest speaker for the above knee and Bologna amputation. So what is above knee amputation? So it is also known as a transfemoral amputation. So this surgical procedure is performed to remove the lower limb at or above the knee joint when the limb has been severely damaged because of trauma, disease, or congenital defect. So most of these specific surgical procedure are performed because of peripheral vascular disease or severe disease of the circulation of the lower limb. So when the limb has poor circulation, it has very limited healing and immune response when we talk about injury. So with this, the foot and leg ulcers may develop, and it will be healed very slowly. So they may become infected, and with this, it will be having a possibility that an infection will occur, and it will spread to the bone, so it will make it severe enough that it could be life-threatening. So if this amputation is necessary, the diseased or severely injured part of the limb will be removed, and the surgeon that will be performing this kind of procedure, it will keep the healthy tissue and bone as much as possible. So the surgeon also shapes the remaining limb to allow the best use of the prosthetic leg after recovery. So above knee amputation is caused by conditions including peripheral vascular disease, diabetes, infection or gangrene, trauma, and tumor or cancer. So let's watch a short video clip about this surgical procedure. So you've just watched the video, a short clip about the above knee amputation. So let's go with the pre-operation. So prior to surgery, the physical therapist may describe some exercises for prep conditioning in order to improve or strengthen your upper and lower extremity strength and flexibility. They will also teach you how to walk with a walker or crutches and educate you about what to expect about the procedure and after the procedure. So for the post-operative care, so the patient should anticipate to stay in the hospital for 5 to 14 days. The wound is should be still be wrapped and a drain may be placed at the surgical site. So medication will be used to control the pain. So when your condition is stable and your doctor clears you for rehabilitation, a physical therapy will begin soon following the surgery. So there will be a physical therapist to come who will be coming to your bedside and review your medical and surgical history. And your first 2 to 3 days of treatment will be maybe include gentle stretching and range of motion exercises, learning to roll in bed, sit on the side of the bed, and move safely to a chair, and learning how to position your surgical limb to prevent contractures. Contractures is the inability to straighten the knee joint fully because of the limb being kept to be bent too much. So let's go with contractures. So a contracture is a tightening of soft tissue that restricts joint motion. So when the muscle soft tissues become stiff because of lack of movement, this disease will develop. So if a person with above knee amputation sits on the same spot for a long period of time, the hip muscles may adapt to the new position and stiffen. And if you lie with a pillow between your legs also for an extended period of time, you may also develop a contracture with your leg positioned too far out to the side. So if these are not addressed after surgery during recuperation and after therapy, they might become permanent. So contractures can make wearing your prosthesis more challenging, as well as walking, necessitating the use of an assisted device like a walker. So for this swelling, it is typical to suffer edema after surgery. Your physical therapist will work with you to keep your compression on your residual limb to protect it, reduce the swelling and healing. Reduce the swelling also aid in healing. So compression can be achieved in a variety of ways, including wrapping the limb with elastic bandages, wearing an elastic shrinker sock. So these methods may also help shape the limb to prepare it for the fitting for the prosthetic. In some cases, a rigid dressing or a plaster cast may be used instead of elastic bandages. An immediate post-operative prosthesis made with plaster or plastic may be applied. This method that you've chosen depends on each person's unique condition. Your physical therapist will help monitor the fit of these devices and instruct you in their use. For the pain management, the use of electrical stimulation and TENS or transcutaneous electrical nerve stimulation for pain modification. So this is a gentle electrical stimulation of the skin to help relieve the pain by blocking nerve signals from underlying pain receptors. Performing manual therapy, including massage and joint manipulation to improve circulation and joint motion. And providing residual limb management, including skincare and proper stump sock use. Desensitization to help modify how sensitive an area is to clothing pressure or touch. So this desensitization, it involves stroking the skin with different types of touch to help reduce or eliminate the sensitivity reaction to the stimulus. So let's go with the Bologna amputation. So it is a procedure that is commonly used to treat foot and ankle disorders. So the BKA or the Bologna amputation, usually it needs a adoption of an artificial leg in order for the patient to walk. So this is done in the area between the ankle and the knee. This amputation is effective for a wide spectrum of individuals suffering from a variety of ailments and traumas. So if you have severe injury or infection, your foot and ankle, orthopedic surgeon may recommend for a Bologna amputation. So an amputation like this may be advised very promptly if you have experienced a catastrophic injury to the lower leg or after attempts to salvage a limb result in significant discomfort or functional difficulties. Non-healing wounds, chronic discomfort, congenital deformities, and tumors are some of the other grounds for amputation. The decision to amputate a limb is based on a number of considerations and is made after a thorough conversation with your surgeon. So, there are some medical reasons for some patients that may not be a good candidate because of these reasons. So first is the poor blood flow. So the patient shouldn't undergo with this kind of operation because an adequate blood flow is needed for the wound healing. So next is the medical problems like severe heart or lung disease, a poor immune system, or breathing problems. Infections or tumors extend above the knee. Um, if an infection or tumor goes above the knee joint, a higher level of amputation may be required. So the above knee amputation is perfect for this kind of case wherein an infection or tumor goes above the knee joint. So next is the scar tissue or skin and muscle loss. So if the patient with scarring or tissue grafting or tissue loss, maybe not a good candidate for the Bologna amputation. So patients need some adequate skin or muscle to heal a wound or to use an artificial leg. Next is the limited knee function or knee pain. So patients who don't have the ability to straighten their knee or have pain and giving way at the knee may find it difficult to use an artificial leg. And lastly, patients who already do not walk or stand due to other reasons may not benefit from the Bologna amputation. So let's watch a short clip um, on how the Bologna amputation is performed. So just watch the Bologna Amputation video on how the procedure was done. So let's go to recovery. So recovery, majority of the patients will be admitted to the hospital for at least one night. So most of the patient can go home if they receive assistance at home and can walk with crutches or walkers. So some patients who require more assistance walking or may have underlying medical issues should stay more in the hospital until they're ready to return home. So within 2 to 6 weeks, the incision will heal. So this can be affected by factors such as a blood flow, skin and soft tissue quality, and medical diseases including diabetes. So swelling is a typical occurrence that might linger for months, if not years. So, like the above knee amputation, um, the swelling for the below knee amputation is addressed with a compression stocking or shrinker. It is an essential for effective artificial leg use. So, if the prosthetic is placed to a swollen limb, it will become loose and as the swelling subsides. So a swollen limb will also not fit to an artificial leg. It could take up to a year for you to fully recover. So during that period, the artificial leg is constantly modified to provide a suitable fit. So that is my um, presentation for you about the amputation in above and below knee amputation. So thank you so much. Well, thank you so much, Mr. Matangit, for that discussion. And before we begin our last but not the least topic for today's webinar, um, there will be an intermission number before we start our next discussion. Thank you so much for that wonderful intermission number. And last but not the least, we have Miss Bridget Don Manungas for her presentation about total knee replacement.
Thank you so much, sir. I will now discuss to you the total knee replacement. So the total knee replacement is a surgical procedure to resurface a knee damaged by arthritis. Metal and plastic parts are used to cup the end of the bone that form the knee joint along with the kneecap. Total knee arthroplasty or the total knee replacement is a common orthopedic surgery that involves replacing the articular surface of the knee joints with a smooth metal and highly cross-linked polyethylene plastic. Total knee arthroplasty aims to improve the quality of life of individual at the end of the with end stage of osteoarthritis by reducing the pain and increasing the function. On the other hand, a total knee replacement involves the replacement of 3 compartments of the knee. So the first compartment is the medial compartment. So this is located inside the part of the knee. Second is the lateral compartment. This is located outside the part of the knee. Then the third is the patellofemoral compartment. This is located in front of the knee between the kneecap and the thigh bone. You may need a knee replacement if you have knee damage that causes severe pain and difficulty doing daily activities such as walking, running, climbing stairs, and other daily. The goal of total knee replacement is to relieve pain and help you move better. People of all ages may have total knee replacement surgery, but it is more common in older people. So the average recovery time from knee replacement surgery is approximately 6 months, but it can take roughly 12 months to fully return to physical demanding activities. The most common cause of total knee replacement is a chronic knee pain and also the disability due to arthritis. Although there are many types of arthritis, most knee pain is caused by just 3 types: the osteoarthritis, the rheumatoid arthritis, and the most traumatic arthritis. So first, let's discuss the osteoarthritis. So osteoarthritis, this is an age-related wear and tear type of arthritis. This is usually occur in people 50 years of age and older, maybe occur in younger people too, because the cartilage that cushions the bones of the knee softens and wears away. The bones then rub against one another, causing knee pain and stiffness. The second is the rheumatoid arthritis. So this is a disease in which the synovial membrane that surrounds the joint become inflamed and thicken. This chronic inflammation can damage the cartilage and eventually cause cartilage loss, pain, and stiffness. Rheumatoid arthritis is the most common form of group of disorder termed as inflammatory arthritis. So the third is post-traumatic arthritis. So this can follow a serious knee injury, fractures of the bones surrounding the knee, or tears of the knee ligaments may damage the articular cartilage over time, causing knee pain and limited knee function. So during the surgery, a surgeon removes damaged cartilage and some bones from surfaces of your knee joints. So the cartilage is tissue that covers your bone where they met. Healthy cartilage is smooth and helps the bone glide over each other when you move. When cartilage becomes rough and wears away, the bones rub against each other, causing pain. So after removing the damaged knee cartilage and the bone, the surgeon attaches the artificial parts to your bone. So the artificial parts are made of metal and plastic. So this will give you a new knee and a smooth surface. So the total knee replacement, the surgeons will replace 3 surfaces. So the first is the end of the shin bone. So the shin bone is the tibia, the larger of the 2 bones in the lower leg. So the tibia is longer bone on the inside, and the fibula is the smaller bone in the outside. So the tabia is much thicker than the fibula. This is the main weight-bearing bone of the two. So second is the end of the thigh bone. So thigh bone is the femur. This is a large upper leg bone that connects the lower leg bones to the pelvic. So the third is the back of the kneecap. So the kneecap or the patella, the smaller bone that runs along the tabia and the kneecap, are the other bones that make the knee joint. So the tendon connects the knee bones to the leg muscle that move the knee joint. So after total knee replacement, you may still feel some mild pain, and the area may be swollen for 3 to 6 months after surgery. Your knee will continue to improve for 6 to 12 months. You probably use a walker for 1 to 3 weeks, then use crutches. When you are ready, you can also use a cane. So probably you will be able to walk on your own for 4 to 8 weeks. You will need to do a physical rehabilitation after a knee replacement. So the rehab will help you strengthen the muscle of the knee and help you regain movement. The vast majority of total knee replacement surgery are successful. However, complications can occur. So complications tend to be higher in patients who use tobacco and who are older or obese. The possible problems after total knee replacement surgery includes infection, blood clots, heart attack, stroke, nerve damage, scaring the limits how far you bend your knee, then especially your age, general health, and how active you are in all affect your risk of having a problem after knee replacement surgery. So aside from risks associated with anesthesia and infection, there are other potential complications. So the first is a prosthesis component can become loose or dislocated if it does not seal to the bone well, or this can cause a misline. So second is the leg may be slightly different length after surgery. In some cases, a shoe insert can remedy this problem. The third is the new knee may be stiff. Most people who will undergo total knee replacement can bend their knees at least 150 degrees. However, some people develop scar tissue that hinders flexibility. This limited flexibility is more common in people who had limited flexibility before the surgery. So the fourth is an allergic reaction to the prosthesis or the bone cement can occur. In this case, the bone cement and the prosthesis must be removed. So there are the 4 basic steps of the total knee replacement. First is prepare the bone. So the damaged cartilage surface at the end of the femur and tabia are removed along the small amount of underlying bone. So the second is the position of the metal implants. So the removed cartilage in the bone is replaced with the metal components that recreates the surface of the joint. These metal parts may be cemented or pressed fit into the bone. So the third is resurface the patella. The undersurface of patella is cut and resurfaced with plastic bottles. Some surgeons do not resurface the patella, but depending on the case. Fourth is insert a spacer. So a medical grade plastic spacer is inserted between the metal components to create a smooth gliding surface. So before I end my presentation, I will be showing to you a short clip on how total knee replacement done.
Total knee arthroplasty or replacement is a surgical procedure in which a diseased or damaged knee joint is replaced with an artificial joint. Your knee is made up of the lower end of your thigh bone or femur, the upper end of the shin bone or tibia, and the kneecap or patella. Most replacement joints consist of a metal femoral component, a plastic tibial component held in a metal tray, and a plastic patellar component. The procedure begins with an incision on the front of the knee, and the kneecap is moved to the side. Damaged bone and cartilage at the end of the femur are cut away, and the bone is measured and cut to fit into the femoral component, which is then attached. Next, damaged bone and cartilage at the top of the tibia are cut away, and the bone is measured and cut to fit into the tibial component. A metal tray is fit against the flat cut top of the bone with its stem inserted into the bone. A plastic insert is snapped into the tibial tray. The femoral component slides on it when the knee is bent. The damaged portion of the kneecap may be replaced by a mushroom-shaped prosthesis. The resectioned patella and prosthesis are attached to other components. Measurements and tests to ensure balance and movement are done during and after surgery. Knee replacement can significantly reduce pain and improve function. Like all surgery, there are associated risks. Physical therapy and realistic expectations are important for successful recovery.
Thank you so much for that wonderful intermission number. And last but not the least, we have Miss Bridget Don Manungas for her presentation about total knee replacement. So this concludes the webinar of Group 4. So I want to thank you all so much for attending this webinar and hope you have learned something from this webinar. And that's all. So thank you so much again and God bless.